Les pido por favor recibamos al doctor Harold W. Kohl III.
Muchísimas gracias, señor, y gracias a todos. Gracias por la invitación a este foro especial. Lo siento por mi español, no es, o es mal, y necesito hacer esta charla en inglés, pero es un gran placer to be here in Quintana Roo. So I will leave it in Spanish and change now to English to be able to make this presentation. So thank you. What I want to talk about today in the next 50 minutes or so is something that I feel very passionately about and that I think we need to be thinking about. As we heard in some of the earlier presentations today, which were very impressive, what I want to leave everyone with today is that physical inactivity should be a public health priority. Much like smoking, much like poor diet, much like infectious disease control, we have to make the case that physical inactivity is a public health problem. Not just a problem for you or me or our parents or our children, but it's a population-wide problem. And that's what I hope to leave you with today, with presenting some recent data and some arguments that I think will be able to convince us on that. It's not just a problem in Mexico, it's not just a problem in the Estados Unidos, it's a problem that's global. And we've tried to address this from a professional standpoint by beginning an international society for physical activity and health, a newsletter. It's a free newsletter if you would like to sign up, globalpanet.com. And it comes out every 2 weeks, and it provides an update for things going around the world, things going on around the world in physical activity and public health. It's a tremendous resource, I think. Before I begin, I would like to thank, obviously, the organizers of Ponte CN. It's a very impressive group. I learned a lot about it in preparation for the meeting today and then this morning. Certainly, Professor Juan has been very, very kind in the invitation and organization to get me here. I didn't have that far to go. Yo soy Tejano, and I think those of us in Texas are brothers with Mexico. Jaime and Laura Fernandez have been wonderfully kind to me in the last 24 hours, helping me along. Most importantly, over the course of my life and my career, students and colleagues and friends, several of whom are here today, Wendy Brown, Sandra Matsudo, have all challenged me and helped me focus on this issue. And I come to you today with the argument, and this is the whole reason why I'm here, that physical inactivity is every bit a problem as these other serious public health issues we've been facing for the last years or so. So I really have 3 goals for today. I want to make an argument and hopefully present the case that physical activity and public health is a separate discipline. It's emerged recently as a separate discipline in the area of health studies. And it's really a result of a marriage between exercise science and public health science. Second, I'm going to make the case, I hope very convincingly, that it is not just a public health problem, but that it's an urgent public health problem. And we have to be dealing with this on a population-wide basis, not just on an individual basis. And then I would be remiss if I did not present some possible solutions to this problem, having spent the first first 2/3 of the talk talking about what's going wrong. I want to present some solutions of where we need to go. So 3 key goals for the next some minutes in the presentation. So where have we been? I'll take you back to 1900, the beginning of last century. We had the evolution of public health science and exercise science continuing on from the beginning of the century forward, separate and not mixing at all. For example, we had in exercise science, a guy named August Crow helped us discover very important things such as carbon dioxide transport, metabolism. It helped us understand how to transport and produce insulin for diabetes. He's a Dane. He was a Dane, and really the first Nobel laureate, the only Nobel laureate that the people in exercise science can claim as someone who's advanced our understanding of how the body works in the most fundamental ways. Those of you who are in physical education, exercise leaders and so forth, our fundamental cycle ergometry that you see in gymnasiums and laboratories and so forth was his original design. A very important person in the early days of exercise science. In the middle of the century in the United States, a gentleman named Thomas Curitin with the University of Illinois spent an awful lot of time talking about physical fitness, popularizing physical fitness as an issue, elite sports, athletics, and was really focused on popularizing this to a point where it became something that people were beginning to talk about outside of athletic circles. He operated in the middle to the late part of the century and really helped us advance. These are examples. Many other people helped us do that. But we had this focus on human performance in exercise science, discovering what the body does, how it does it, and how to maximize performance. At the same time, examples in public health, which are some of my favorite, include a nurse in New York City named Sarah Josephine Baker. She worked very hard on helping prevent infant blindness, promoting school health for children, one of the first people in the world, at least in the United States, to recognize that schools would be a great place to promote health for children. She was one of the first to ensure licensure of midwifery and promote that as a way to help children have an early and positive start to being healthy. She operated again at the turn of the century, forward for the first half of the century. One of my favorites, and we don't necessarily have a lot of public health people here, but one of my favorite examples is this gentleman here who was a dentist. And in the United States, in Colorado, there's an area where it's very mountainous. And a friend of his wrote him one day and said, I have these people living in this village with perfect teeth, no problems whatsoever, except they're very brown. He didn't know what to do about that. So he went and traveled and examined them and tried to figure it out. He tested the water supply and found extremely high concentrations of fluoride in the water, which was causing the brown stain, the Colorado brown stain in these people. But then he put two and two together and realized that it was the fluoride, the high fluoride concentrations, that was protecting their teeth from problems, from cavities and so forth. Classic public health translated that into what we do now, which is a few parts per million of fluoridation in water supplies, and the dental caries and decay in populations have dropped dramatically. A classic public health approach, which was going on at the same time that T.K. Curitin was talking about fitness and athletics and high performance in physical activity. So these things were all going on, these things were all going on simultaneously at the turn of the century, but they weren't talking to each other. It was exercise for performance and public health advances such as these others, hygiene, immunizations, penicillin. All of these things came across in the middle of the last century, but they weren't really applied to what we know now as exercise science. In 1953, something very important happened, extremely important happened in this field, physical activity and public health. And that was the beginning of population studies. Population studies took a look at this issue from a health standpoint. Exercise for heart health, not for performance necessarily, not for maximizing gain in sport or anything else, but how it faced with health. And this is really a classic story in this field. A guy named Professor Jeremy Morris in London studied London transport workers. And he compared the rates of heart disease death between the conductors who ran up and down the stairs all day collecting tickets and the drivers who remained sedentary. And today it's pretty straightforward and simplistic, but at the time there were no data, and not surprisingly, the conductors who were exercising all day, being physically active, were much less likely to die of heart disease than the drivers. And a field was born. All of a sudden, we saw this broad set of studies emerge after 1953, helping us to formulate there's something going on with physical activity and health. There were a lot of, we talked earlier about guidelines for Mexico, which I think is a terrific idea. Some clinical guidelines began really after these first studies. A rapidly evolving science base indicated that physical activity had something to do with health. It wasn't just for performance, but there was something going on. We didn't know exactly what, but there needed to be some professional guidance. There were a lot of individuals at the time promoting health-oriented fitness programs, books, and things like that, but we didn't know which was best, which was important. And in this 20-year period, it really began to be a popularization. In the United States, Jack LaLanne, a very big muscle strengthening advocate, came to fore, TV shows and things like that. And it wasn't that long ago either, in this period of time, that there was concern by the medical community of safety. It was in my lifetime that cardiac rehabilitation, people who had had a heart attack, were told to rest in bed for several weeks before they got up. Now it's been totally changed. But at the time, there was really there was a concern in medical professionals that this might actually be harmful. It's amazing how far we've come over the years, though. And we fast forward to the mid-1970s to mid-1995. The organizations such as the American Heart Association, American College of Sports Medicine started to publish guidelines for professionals, what to do with your patients at this point in time. If you're a physical educator, a physical therapist, how to safely train people so that they can increase their fitness, but do it in a safe manner. Okay? But it was focused on individuals, you and me, your patients, the people in front of you, rather than populations. That's an important distinction I'm going to continue to go through. Heart Association and American College of Sports Medicine all kind of put these things together, and they continue to be evolved over time. But this early leadership was really critical to bring the importance of physical activity for clinical medicine to an area where we didn't have before. And we started to see a very prescriptive approach to physical activity. Here I've just graphed 1975 to 2005, a 30-year period. It came out periodically. They were largely focused on the type, intensity, duration, and frequency of physical activity. What is it, aerobic or endurance exercise? A very, very complicated approach to intensity, 60 to 90% of VO2 max. Who knows their VO2 max in the room? A couple of people is all. How do you do that? How do you translate that to people who want to become more physically active? You'll see, importantly, that the intensity recommendations over time actually declined. The literature is evolving, the science is continuing to mature in this area, and we started to understand that it wasn't exercise for performance only that related to health. It actually started to look like more moderate intensity activity had some benefits. Walking instead of running marathons. physical labor, transportation-related physical activity. A very different view than what we were looking at in the previous 20 years that really focused on how to maximize cardiovascular performance and so forth, particularly for athletics, which is the roots. Our roots in this area began with athletic performance and exercise science. And we started to see in the mid-90s, in response to this obesity problem that we have, not just in Mexico, not just in the United States, but in developing countries now throughout the world, starting to become a problem. A caloric expenditure, a weekly caloric expenditure equivalent, 800 to 1,000, what the studies showed and so forth. The point I want everyone to leave here with is it's a very, very clinical approach to exercise prescription, right? What your physician, what physical educators, what others can do to do that. And in 1990, I think something very important happened. And history, I think, will treat the year 1990 as the period, as the year where physical activity expanded from a clinical problem to a public health problem. How do I say that? The American College of Sports Medicine published a very important position stand where they continue to update based on literature and so forth. But they acknowledged a very important emerging set of literature. Since 1978, an important distinction has been made between physical activity as it relates to health versus fitness. It has been pointed out that the quantity and quality of exercise needed to attain health-related benefits may differ from that recommended for fitness benefits. Wow. An incredibly important acknowledgement that this science is changing this. It's not excluding one or the other, but that the health benefits are starting to be recognized much more than the performance benefits. It's now clear that lower levels of physical activity than recommended by this position statement may reduce the risk of certain chronic degenerative diseases and yet may not be a sufficient quantity or quality to increase maximal oxygen uptake, changing fitness. This is one of the largest professional organizations in the world that's now saying, well, there's something to this science that's beyond just what we've been saying all along. From this very clinical approach, okay? I don't know how to tell my mom to exercise at 60, 90% of her VO2 max, to something where there's an acknowledgement that it may not be as complicated as that. ACSM recognizes the potential health benefits of regular exercise performed more frequently for a longer duration of time, but at a lower intensity than actually prescribed. So 50 years from now, when the archaeologists blow off these compact discs or whatever they're going to be stored on, and we take a look at this again, I believe that 1990 is going to be an extremely important time in the development of this subdiscipline of physical activity and public health. Going to the early 90s now, literature is emerging on the accumulation of moderate intensity exercise that are actually providing health benefits. In the United States, there was an admission that only 10% of the adult population were actually meeting the guidelines that ACSM had put down in terms of intensity, frequency, and duration, and so forth. I'm not a behavioral scientist, but a lot of people who know a lot more about it than I do have stated that this idea of only working in vigorous, only working in a training model, an athletic training model, may actually be a barrier for many people, right? Behaviorally, they say they can't do it for one reason or another, and therefore they don't do anything at all. But probably the most important point that the realization here from the early 90s was that the public health gain, a public health gain, could be realized by avoiding sedentary behavior, by avoidance of being sedentary in general. And we started to see this emergence of these patterns that are showing up with increases in the risk of disease and increases in physical activity for many outcomes: heart disease, stroke, diabetes, falls, functional health status for older adults. Musculoskeletal injury. All of a sudden, there's this admission much like understanding immunization patterns and risks of different vaccines, that there's actually a risk associated with physical activity as well. And from a public health standpoint, we have to understand the risks as well as the benefits. Osteoporosis and bone health, and then here, what we're talking about in terms of this is prevention of weight gain and energy balance for this forum. So we started to see this extremely consistent pattern, not similar for every disease outcome, but this extremely consistent pattern where at the highest levels of physical activity, we saw the lowest risk of diseases and death. But importantly, the biggest potential gain in a population is moving from here, low physical activity, simply into this area, not to running 10Ks or competing for in the World Cup, elite athletes, things like that. The population benefit seems to be right in here. A major understanding, I think, and a major shift, not one versus the other, but I think moving things over to allowing this idea that there could be a public health benefit. Extremely important here in the early 90s. We saw things such as the U.S. Surgeon General's report on physical activity and health, consensus statements, and the first set of physical activity recommendations from the Centers for Disease Control and the American College of Sports Medicine. We went from that very complicated 60 to 90% of your VO2 max on 5 or more days a week to this statement. This is much easier for my mother to understand. From a population standpoint, this is much easier and much more in line with where the science had come for the last few years. Every adult American should accumulate at least 30 minutes of moderate to vigorous physical activity on most, preferably all days per week. I think the circle then becomes complete when you start to make this argument that this is now a public health guideline recommendation. And then most recently, the World Health Organization, Australia, the United States, others have come out with updated physical activity guidelines that are standalone pieces. And the current recommendation, I think the consistent recommendation, is a minimum of 150 minutes a week of moderate intensity physical activity. But more benefits happen with more intense and a higher volume of physical activity, 300 minutes or more a week of physical activity, of moderate intensity physical activity. So we've expanded this now, and we've created, I think, the subdiscipline based on the science, based on an understanding of public health, that this has now become something that we have to focus on. We've shifted from these early guidelines that focused on training for performance, understanding that increases in aerobic capacity, our cardiovascular fitness, are most rapidly achieved by increasing the intensity of endurance exercise, to a physical activity and health paradigm. That activity actually increases health, and that these data from observational studies and other kinds of things demonstrate there are health-related outcomes associated with lower intensity, less physical activity than may be necessary for human performance. Critical piece, and I'm pleased to say that I was, I hope, part of that period of time. So we had the development here of this field. I'll revisit my pyramid. Seems appropriate here in the Yucatan to talk about pyramids. Exercise science, public health science. 1953, we saw the appearance of population-based health studies. Talked about that, accumulation of literature. What do you do about it? Really, it's only been in the last 30, maybe 25 or 30 years that we saw this appearance of behavioral science. How do you change someone's behavior? How do you take this information we have and actually help people become more physically active? We learned a lot from smoking cessation, other health behavior change types of studies, and applied it to this. It's only a very, very young field, though. We think we know some things. We've learned some things. Not perfect, but I think we've put this together to a point where we're understanding some of the behavioral reasons why people are physically active. And then finally, only in the last 15 years has our understanding of how the environment plays in influencing people's physical activity has really come to fore. My good friend Jim Salas, who's a very important person in this area, actually developed this whole field. And he likes to say that I can get anyone to exercise. I can put them onto a treadmill, tie them down, and they'll exercise. But when you put them out into the environment from which they came, where there's no places to be active, where it's not safe, where it's perceived not safe, then you're setting them up for failure. And so this understanding of how policies, physical education policies in schools, transportation policies, of how the built environment influences physical activity is in its infancy in relation to these other kind of things. But taken together, this whole pyramid is now teaching us that this is actually a field of study. If you put all of these pieces together and build them, we've created something that wasn't there 20 years ago. And that's this idea that physical inactivity is a public health problem and is its own discipline. It's important, much like nutrition and smoking, but it is a distinct area of study, a distinct area of public health that we have to continue to grow. This is a nice painting from a Flemish painter in the 1560s. You can see many happy children playing in the square, enjoying things. Maybe they're fighting here a little bit, but all in all, it's a very happy scene. And it conveys, I think, maybe an idyllic or an optimal setting, but it is in fact happy. What have we done today? We've actually engineered physical activity out of our daily lives. And thanks to Photoshop and other kind of things, you can find all the children in here in the screens and hiding. There maybe one guy stealing some bread or something there, running away. But other than that, the environment has totally changed, right? We have effectively changed and engineered physical opportunities for physical activity out of our daily lives. And while I'm not going to give up my television remote control anytime soon, we have to start thinking, I think, in a public health setting about how we're going to actually take an understanding of this and move it forward to find other opportunities to put physical activity back into daily life. 2 summers ago, we published a series of papers in a medical journal called The Lancet from the UK, a very, very well-read journal. And these words on the front, I think, are as important as I've ever helped write in terms of helping to understand this problem of physical inactivity as a pandemic. In view of the prevalence, the global reach, the health effects of physical inactivity, the issue should be appropriately described as pandemic. Oh, that sounds serious. Well, I think it is. It's a pandemic with far-reaching health, economic, environmental, and social consequences. Let's explore that a little. Oh, well, this is from my hometown in Austin, where the cows are as big as the cars. What constitutes a public health problem? It's very easy for us to say these words, and you hear them frequently. I use them a lot. I teach students and so forth in public health. But what actually makes a public health problem? 3 things. Is it important? That is, does it have some kind of effects that are important to the population or to the people affected? Does it affect a lot of people? Is there a large prevalence? Are there trending up and down, a variety of ways? What does that look like? And then finally, are there solutions? You can have something affecting a lot of people. You can have it being very important, but if you don't have any solutions, then it may not be a priority for public health yet. You can have solutions, you can have importance, but if it only affects a few people, then it may not yet be a public health problem. It may be a clinical health problem when you're dealing with a healthcare setting. The Ebola outbreak in Africa is very important. It affects, I think, at last count, about 1,000 deaths. And we have to watch it closely. But is it pandemic? Is it something that we should be dealing with worldwide yet? The answer is no. We have to attack it where it is right now. When we talk about population health, it's not just about the individuals. The individuals make up the population, certainly. But when I'm talking about public health, is a variety of other kind of things. Understanding the pathophysiologic pathways, understanding the genetics, understanding what individual risk factors, whether they're blood pressure or cholesterol or things like that are, social relationships among individuals, the environment, communities, institutions, and then finally social and economic policies. What I'm arguing for is reframing the problem of physical inactivity into this kind of a public health issue. It reaches all of these levels. Yes, it has economic impacts all the way down to individual health. But if we only focus on what the individuals do, this does not become a public health issue. And that is my main message today. One of the most important papers I've ever read was from the best epidemiologist I have ever known, and that's Ai-Min Lee at Harvard University. One of the papers in the Lancet series sought to understand the effect. Is it important? Our first category. Is it important to populations, to public health? I'm having trouble, sorry. Can I go back one, please? Regreso uno, por favor. Yeah, thank you. She and her colleagues took a look at some of these data from around the world, and the importance is, the calculations are not important right now, but estimated essentially the total number of deaths due to many non-communicable diseases. The total number of deaths, or the percentage of deaths around the world, in country by country, that could be attributed to physical inactivity. There are some calculations, some other things you could do as an epidemiologist. But the take-home message here is that between 5 and 10% of all heart disease deaths in the world, developing countries, developed countries, and so forth, can be attributed to physical inactivity. If you magically wave a wand and make everyone who's inactive active, between 5 and 10% of all deaths due to heart disease would disappear. We would lower the mortality worldwide by 5%. Between 6 and 12% of type 2 diabetes, 6 and 17%, breast cancer, colon cancer are hovering around 10%, and then deaths due to all causes between 8 and 12%. This is worldwide. This is a public health issue. If you could say, I could do something tomorrow to reduce 1 in 10 deaths, that would be a major public health win, and I think that's what we're looking at here. Taken another way, 6%, these are the averages, 6% of heart disease, 7% of diabetes, 10% of breast and colon cancer, 9% of premature mortality. It varies widely depending on the country you're in. But this is a major statement forward. Translating it forward into Mexico, specific to this country, a little bit higher on premature mortality, a little bit higher on cancer, colon cancer, about the same on breast cancer, and a little bit lower on heart disease and diabetes. It's still critical to address. If you could prevent 6% of coronary heart disease deaths by changing physical activity habits, this is something we should do. If you could take a pill to reduce those deaths by that amount of money, or by that amount of the number of deaths, it's something we should do. It's taking the exercise pill, if you will. You can impress your friends and family with this particular slide. The estimate, if you translate that into the kind of the total number of deaths in 2008, would be about 5.3 million deaths around the world. taking the numbers and moving them into rates, weighting them by countries. It's a complicated analysis, but this is the bottom line. The important point here is that similar calculations for smoking are in the same neighborhood. Physical inactivity is every bit as important as smoking in reducing a risk of mortality and non-communicable diseases. Whoa. That gets people's attention because smoking has been such a problem for so long. And from a population or public health standpoint, this comparison is extremely important to convey and to create this importance of physical inactivity as a public health problem. So yes, it's important. Estimated about 2/3 of a year life gained on the average. It's more among people who are physically inactive, but overall, combining active and inactive people, it's about 2/3 of a year, 0.68 year. I'd like to have another 2/3 of a year of my life extended. So yes, is it important? First category of public health problems, yes. Is it a pandemic? Well, we think of these creepy things when we think about pandemics, Ebola and can you, próximo por favor? Regreso. Well, we think about these problems. We think about these major scary things, H1N1 virus, avian influenza, all of these things that become scary because we can't see them. When in reality, compared to 5.3 million deaths in 2008, there are very few other things that have the population burden, and that's kind of a key message. What is a pandemic? Well, it's an epidemic that occurs worldwide or over a very wide area. It crosses international boundaries. It affects a large number of people. Well, do we have that? First, what's an epidemic? The occurrence in a community or region of cases of an illness, my bold on the wording, specific health-related behavior, or other health-related events clearly in excess of what's expected. Does physical inactivity meet these definitions? I think it probably does. We'll take a look. Próximo. So one of the other papers in this series was published by a good friend, Pedro Halal, from Brazil. And he took a look at the global physical activity levels. Does it cross international boundaries? Boiling it down to a couple of slides here, the numbers are not important in this particular slide. Red is bad, blue is good, or less bad, and white means no available data right now. This is for men and women, adults 15 years of age or over. You can see here in the Americas, Canada, US, Mexico, kind of similar, 30 to 39%. Brazil, South America seems to have a problem. And so this is the best data we have available where you can compare countries. Is it a pandemic? 1 out of 3 adults are not meeting physical activity guidelines around the world. It varies, obviously, by country. But if 1 out of 3 adults were smoking, what would we be doing? We'd be putting an enormous amount of effort into smoking cessation and other kind of things. It's every bit as important as smoking. We should be addressing it. What about adolescents? Próximo. Here we are. Boys and girls, again, the numbers are not important here, but red is bad, blue is less bad, and white means there are really no data available for these 13, 15-year-olds. I think it's probably changed for Mexico and a couple other countries since these data were published. Próximo. If 8 out of 10 children, if 8 out of 10 adolescents were smoking or had poor diets, what would we be doing? We would be crazy with responses, public health responses, policies, interventions, other kinds of things to try to manage this problem. 3 out of 10 adults, 8 out of 10 children are estimated to be not meeting the minimal physical activity guidelines. It's a public health issue, and because it crosses borders, it is a pandemic. It requires a response that is extremely aggressive, and it's an urgent problem. Approximately. We do know why some people are active and some people aren't. Another really accomplished scientist, Adrian Bowman from Australia, led this paper on what the literature shows on why some people are active, why people aren't. And really complicated models taking into account factors at the individual level all the way to the global, regional policy level. Things like we're talking about here. This is a very impressive group of people who've been assembled. State sports officials, national ministry officials, private foundation individuals, because it in fact crosses all of these various areas, from young life all the way to older adults, and it becomes very complicated very quickly. But we do know that we've got a lot to learn, I think, is the bottom line. And I'm not going to get into really critical kind of things, but the important, really complicated explanations of this graph. But the important point to take away is, beginning right down here in the early 2000s, there were very few studies that helped us understand in children, adolescents, and adults what some of these correlates were. Less than 20 studies. How are we going to attack this if we don't know what some of these reasons for determinants are? Happily, we're starting to see this increase in studies over time, and that will continue. But the trend here is something that I think bears watching. We do know that from non-environmental factors, males are more likely to be active than females, both for children, adolescents, and adults. How well people believe they can be physically active is very consistently related to being physically active. Whether or not they've had previous experience of being physical, such as sports. CONADE is a very important partner in this effort, because getting early positive experience for sports and exercise participation seems to be related to people who are going to be more active throughout the day, or throughout their life. And then environmental factors. There are not just individual, but environmental factors. Association with access to recreational locations and facilities. Does the neighborhood design affect it? Yes, it seems to do that. Transportation environments, how well people can be active during a transportation event and so forth. We're starting to understand this, and it's becoming much clearer than we had even 10 to 15 years or so ago. Okay. Many potential factors are studied. The take-home is that gender and physical environments for children and adolescents seem to be pretty consistent. For older adults, age, gender, health status, and education, whether or not they're confident, success with previous physical activity, and so forth. The emerging literature in this area, I think, is important, and there's some environmental correlates. The top of the pyramid in the emerging discipline. Third, what do we know what we can do about it? Well, there's actually quite a bit of evidence, quite a bit of scientific evidence that's available on what we can do about this. And this is reserved for another lecture, but we have recommended approaches, strategies that are effective or promising that allow us to develop these campaigns, develop these interventions, these community changes, all the way from changing urban design and land use policies, transportation policies and practices, all the way down to point of decision prompts, putting a little card on the elevator saying take the stairs rather than take the elevator, seems to help people to make these conscious decisions. One of the previous speakers also mentioned the work that's going on in Brazil with the public spaces, physical activity in public spaces, a tremendous advance in our understanding of how to help people be physically active, particularly in Latin America, using those public spaces. So we do know what to do. In many cases, there's evidence. It's continuing to emerge. But the third leg of the public health problem, is it important? What's the prevalence and trends? Do we know what to do? I think we actually have quite a bit of information to be able to start this. And that's what this forum is about, is how to put this kind of evidence into action for Mexico. And I think it's a tremendous step forward. Prevalence and trends, 31% of adults worldwide not meeting recommendations. I didn't touch on this, but there's a particular concern with developing countries on increasing urbanization. People moving from the country to the cities and towns, and the loss of transport and occupational related physical activity is really driving this major shift in the prevalence downward. It's important, a large magnitude and a large risk. There are global consequences. I didn't talk about quality of life as well as economic issues. We know what to do in many cases. It is a public health priority. And I hope I've tried to convince you that, in fact, this actually is as important as tobacco control and these other problems we're dealing with for non-communicable diseases. Finally, just a few moments before I wrap up on what to do about it. I think that this is a paper that several of us put together as also part of the thing, and it talked about, it was used specifically as a call to action. And this forum right here is a tremendous, I think it's right in line with what this paper called for in terms of what has to happen. A trans-sectoral approach to making this a public health issue. What's the way forward? We focused oftentimes on individuals. I started talking about clinical approaches to exercise prescription. And behavioral science has really focused on individual behavior change, taking a group of people, exercising them for 15 weeks, seeing what happens, seeing how long it takes them to become sedentary again. And these models, these behavioral science models, have really helped drive a lot of what we're doing in that area. We've learned a lot. But from a public health standpoint, I argue that they're not applicable because they change individuals and focus on the individual rather than on the population. The fundamental assumption that health behavior change equals public health, I think, is flawed. I think that we've focused on these individual areas, exercise science, public health science, behavioral science, environmental science, as I've developed a cartoon for the, how the field looks. But public health requires an integration and understanding of the interrelationships, the multiple levels, all at the same time. The upstream approaches, the fluoride in the water supply. Where is our fluoride in physical activity? Where is that upstream change that can help us re-engineer physical activity into our daily lives? And this is a dead horse. I think we've ridden that horse for public health as long as we can. And we have to take the next step to understanding how these systems work together, how people live their lives, rather than just individually adapted behavior change. This is one of my favorite quotes. Those of you not in public health, I think, can understand this very easily, and it's an important point. The whole concept of public health is founded on the insight that health and illness have causes or conditions that go beyond the biology, the pathology, and the behavior. Public health encompasses a much broader things, such as socioeconomic status, environment, and these other kind of things that we're dealing with. We have to make physical activity a public health issue. Sorry, approximately. Requires thinking differently. This is on the other side of Easter Island. No one really sees this particular set of sculptures. Where'd it go? And it requires understanding complex systems that go beyond a simple behavior change intervention and expecting people to change their behavior overnight. It's a complex problem. It's not simply saying you should get more exercise or just saying, here's what you do. We have to be thinking in terms of complexity because, like this guy right here, if he's got a problem, he can fix it real easily. But if he doesn't consider the system he's in real trouble. Right? He's in a problem because he's not considered the system. And I think from a public health standpoint, we have to start thinking system-wide in terms of this. And systems approaches to this recognize the complexity of the behavior. It's not simply a linear approach to this. Figure out these ideas, these trans-sectoral ideas, and how people live rather than trying to adapt or change people within the one system. I think it has the highest potential to affect population levels of physical activity if we embrace it and think about it from a public health standpoint. I took this photo 2 years ago at the American College of Cardiology meeting in San Francisco, California. These are cardiologists, very smart people, and they can't figure it out. How do we expect people who aren't smart, not who aren't smart, but people who deal with things and don't understand the biology of this? This is not as easy as building a stairway and expecting people will take it. These are cardiologists. Now, they might have all ran 5 miles in the morning before the Congress started, but I highly doubt it. We have to start thinking more than just a simple univariate changes in physical activity. This is what we've been doing so far, and I'm going to wrap up with this point. We've had this problem, physical inactivity. And from a behavioral standpoint, health behavior change, we want to do something about it, right? We design this, we put it into a theory, and the behavioral scientists help us understand these kind of things. We do an intervention, and we get a behavior change. Great. Publish a paper, get invited to meetings all over the place, and all of a sudden you know what you're talking about. But we really haven't changed the system that these people are in. We've taken a change on the individual, right? And then we've had this emergence of environmental change recently, which I think is terrific, where we take a problem, physical inactivity, do a policy or environmental change, require school physical education, or require sidewalks in new neighborhoods or neighborhoods that are being renovated. We do the intervention and we get a behavior change. We focused on kind of an either-or kind of situation. And that's been great. We've learned a lot, I think. But I think what we've been missing is this idea of how and where people live and how they apply, how this applies to the system that people live in. We've got the same problem, and recasting this, same problem as physical inactivity. Approximately. We want to get a behavior change, same kind of fundamental issue, but we're going to go at it a little bit differently. We're going to think about this behavior change theory, environment change policy, implementation strategies. Notice I didn't use the term intervention. I think we have to go beyond intervention to make this a public health issue. But we are starting to incorporate, like we have here, the education sector, how people, where people go to school, the health sector, planning, urban planning, the built environment, transportation, the workplace, sport and recreation, CONADE, for example, and so forth. Think about this in total, rather than an individual kind of a setting. How they interact, and then importantly, how some of these things can work for and against behavior change. What are the unintended consequences? What happens if you implement a physical education policy in schools, but the classroom teachers are against it, like we do in the United States, because they think more classroom time is necessary for better test scores, better academic test scores. That's an unintended consequence that we have to deal with from a public health standpoint. Are there competing actions? How do people adapt to these changes? Are there things that inhibit, delay, or accelerate these behavior changes? All of these things from a systems perspective, I think, is where we need to be going to be able to enact this and deal with this problem in the physical, as a public health issue and a public health problem. This is a very close monument here in the area. I hope I've been able to now at least set the stage for the rest of the Congress. I think what's happening in the forum here is wonderful in the Ministry of Education, the Ministry of Health, the CONARE, other people are starting to talk and work together. And I think we're getting to this point where we're starting to realize that what's necessary is a systems approach to doing this. And I submit that what we have to do is continue to make physical inactivity a public health problem if we're going to make any changes and improve health around the world. Muchas gracias por su atención.